Good afternoon. I'm Ann Greiner, President and CEO of the Primary Care Collaborative, and I'd like to welcome you to the Primary Care Collaborative's May webinar. It's focused on accountable care organizations and what the research tells us about their effectiveness. This webinar is hosted by the PCC, and for those of you who may not be familiar with our organization, let me take a moment to describe who we are. We are over 60 organizations strong from nearly every stakeholder group in healthcare, a very diverse set of members. But what we all share is a common passion and commitment to strengthening primary care, because we know it is the foundation of a high-performing healthcare system. All the evidence points to when you invest more in primary care, you get better population health outcomes and more equity. This webinar is part of Better Health Now. This is a campaign that the PCC launched at the end of March to move the National Academy of Science, Engineering, and Medicine recommendations from their primary care report, specifically the payment recommendations, from paper into policy. And we know that if we advance these recommendations, which are to move payment to a version of a hybrid payment, fee-for-service and a prospective payment, and if we invest more in primary care, we can achieve what we want to achieve with advanced primary care models. So I invite you to join our wonderful experts here today to prepare your questions for a Q&A at the end. Now let me introduce you to Pham, who is the moderator for our panel. Dr. Pham is a general internist and national health policy leader. She is president and CEO of the Institute for Exceptional Care. And most recently, she was Vice President Provider Alignment at Anthem, our nation's second largest insurance plan. There she was focused on value-based payment initiatives. Prior to Anthem, Dr. Pham served as Chief Innovation Officer at CMMI, where she was founding official and the architect of Medicare's foundational programs for ACOs and primary care. She was co-director of research at the Center for Studying Health System Change, where Mai and I first met, and she's published extensively in the medical literature. She also serves on numerous advisory boards, including the National Advisory Council for the Agency on Healthcare Research, or AHRQ, the Maryland Primary Care Program, and the National Business Group on Health. Let me turn the baton over to Mai, and thank you again for joining us today.
Thanks so very much, Ann, and welcome everyone. First, just a few housekeeping reminders that all of your lines are automatically muted, but we'll take questions from the audience in the last few minutes of the webinar. So please feel free to submit any questions you have at any time into the question box. We are recording this webinar, and the recording and slides will be posted within a day after we're done. So in terms of the layout for this webinar and the topic, the Medicare Shared Savings Program, which was launched in 2012, coming out of the Affordable Care Act, now covers 11 million Medicare beneficiaries and is the most studied ACO model. And what we want to ask our panelists is to share what we have learned to date. Do we understand what factors influence ACO performance on quality and cost? What role primary care plays within ACOs? And what program features might be changed to harness primary care's power in an even more optimal way to improve outcomes. There was a recent New England Journal of Medicine perspective suggesting that CMS and CMMI officials are interested very much in the community's input on the Medicare Shared Savings Program. And then we want to broaden the discussion with you to ACOs in other contexts as well. So let me first introduce our two panelists. Jonathan Gonzalez-Smith is a research associate at the Duke Margolis Center for Health Policy, where he's responsible for helping to lead the center's work on international models of accountable care, health financing, global health innovation, and payment and delivery reform. His research focuses on how to support health system transformation at the organizational level, regional, national, and international levels to achieve better population health while still promoting efficiency and equity and high quality. Previously, Jonathan worked as the legislative director for Texas State Representative Terry Canales and as program assistant for the national think tank Demos. David Muhlestein is Chief Strategy and Chief Research Officer for Leavitt Partners, where he's responsible for strategic planning and leads the firm-directed research. David's work centers on healthcare payment and delivery transformation, understanding healthcare markets, and evaluating how the broader system is changing. David's also a visiting policy fellow at the Margolis Center for Health Policy at Duke, adjunct professor at Ohio State University College of Public Health, and a visiting fellow at the Accountable Care Learning Collaborative. He previously served as adjunct assistant professor at the Dartmouth Institute at the Geisel School of Medicine at Dartmouth College. So with that, let me turn it first over to Jonathan to share some of your insights.
Great, thank you. And can you hear me okay, just to make sure? Great. Well, thank you for the opportunity to present. My name is Jonathan Gonzalez-Smith. I am a research associate at Duke Margolis. And for those of you who are not familiar with our work, we are an interdisciplinary group housed within Duke University, focusing on helping informing the implementation of evidence-based policies at the local, state, and international level to help improve health and health care. So in terms of my brief remarks today, I'm first going to provide a little bit more context and sort of background and landscape discussion on ACOs, both MSSP and some other programs, as well as diving a little bit into the evidence base on performance and how ACOs have performed to date. And then I'll close out with a little bit of a future perspective and reading the tea leaves and some of the policy developments that Mai hinted at that have come out of the last 6 months. So to kick things off, I'm going to talk about something that may be very familiar to some of you all, but for those of you who aren't, I think it's helpful to ask why ACOs were introduced to begin with. And the answer to that question is there were and continue to be significant challenges with the way we pay for healthcare and health services. Fee-for-service, which remains the predominant way that we pay for care in the US, rewards greater intensity and volume of care. And what that means on the ground is that we often pay for things that aren't necessary, and we don't pay for things that are, like care coordination. This has detrimentally impacted patient outcomes, the health and well-being of our communities, and encourages wasteful and unnecessary spending. So over the last decade, and really jump-started by the ACA, there was a growing consensus that new payment models were needed to improve the fragmented and siloed approach to healthcare. There's been a concerted effort over the last decade to move away from the existing volume-based payment model and instead more towards payment models tethered to the value of care provided. Accountable care organizations, or ACOs, emerged as one approach to better encourage the efficient delivery of care. They are essentially a structured framework for a group of providers to come together and be responsible for coordinating high quality care to the patients they serve. But in practice, payment and care delivery transformation is not easy. It takes a lot of time, resources, and technical know-how. And I'd like to come back and highlight some of these challenges, both in my slides and in the Q&A coming up. So there are 2 points I'd like to make with this slide. First, I think it's helpful if we keep in mind that while we're talking about ACOs today, ACOs are sort of one of many approaches for how value in healthcare can be achieved. This is encapsulated by the figure produced by the Healthcare Payment Learning and Action Network, which provides a taxonomy for different payment models. From the left-hand side, which is purely fee-for-service, not linked to value, to the more population-based payment models, increasingly linked to value on the right-hand side. The second and related point I'd like us to keep in mind is that ACOs are fundamentally an organizational infrastructure, and that the payment model design can vary depending on the ACO. The vast majority of ACOs operate in that land category 3, which is a fee-for-service foundation with some degree of financial risk and payment model tied to, or payments tied to value. But directionally, where I think CMS and other payers would like to move is away from that category 3, from the fee-for-service foundation, towards more population-based payment models seen in category 4. And ACOs are a step to get there. Over the last decade, as I mentioned, CMS and CMS Innovation Center have introduced a number of programs to spur ACO adoption. This has evolved over time from the original Pioneer ACO program introduced in 2012 to the recently announced ACO Reach. And there are a few things I'd like to note here. First, these have primarily been more Medicare focused, though there are a number of Medicaid and commercial-led opportunities for ACOs, and those opportunities have increased over time. Second, and related, a lot of the research and discussion to date has focused on the Medicare Shared Savings Program, in part because the vast majority of evidence comes from MSSP. It's studied heavily because the data is publicly available, and it's also a foundational program that has helped drive ACO participation across other payers. And then third, in the context of today's discussion, it's important to note that while several population-based payment models, including MSSP, have contributed to increases in primary care participation, on a whole, they have not spurred significant movement of primary care as a whole into value-based payment arrangements. And part of that ties back to the challenges around the issues related to the resources, time, and know-how, which create barriers and impediments to entry for many smaller primary care-based practices. So in terms of the overall landscape, roughly 40% of total US healthcare payments were tied to some sort of advanced value-based payment model in 2020. And by advanced payment model, I'm referring to the land category 3 and 4. But as you can see, this varies by payer, with higher rates of adoption in Medicare than in Medicaid. Though our research has found that this is beginning to change, and David might expound on this in a little bit, as commercial and Medicaid contracts have continued to increase steadily. And part of this is also driven by flexibility in the commercial market and the increasing number of states that have implemented managed Medicaid programs, with at least, I think, 40 states using some form of managed Medicaid for their Medicaid population, in at least as of 2019. But ACO growth, particularly in the Medicare program, has plateaued in the last few years. Again, David might provide a little bit more substance to this slide, but to why we've seen this leveling off, I think, can be attributed to several factors at play. Partly, there's an overall focus from CMS and CMMI to encourage organizations to move into more downside risk arrangements. This was demonstrated in the 2019 Pathways to Success rule, which overhauled MSSP and sort of truncated the time that organizations were required to move into downside risk arrangements. And this increase in downside risk adoption, particularly in the voluntary models, has driven organizations from participating. There were also pauses to programs at the federal level, like direct contracting, which may have dampened enthusiasm, as providers at the sidelines may have been waiting to see where the chips were going to fall. And the pandemic was a significant disruption for providers that were maybe thinking about moving into value-based payment arrangements, though we've seen that those organizations already operating in value-based payment arrangements were much more financially resilient and better prepared to respond to the pandemic than those in fee-for-service arrangements. And lastly, we've seen that the stagnation, as this graph sort of illustrates, was a trend that preceded the pandemic. And one of the reasons demonstrated on this next slide is that it takes time to be successful. We found in our work that ACOs have an initial learning curve and need a period of about 1 to 3 years to get acclimated to the MSSP program. And as you can sort of see in this data, ACOs that are more experienced seem more likely to achieve savings, with about 52% achieving savings in their third year and 83% doing so in their fourth year of participation. Now, part of this might be attributed to survivor biases, those that aren't doing well drop out after their contracts terminate, but it also just takes time to develop the capabilities, the technical infrastructure to forecast utilization trends and predict benchmarks, et cetera. So there's certainly something that we've seen both from an anecdotal and a qualitative and quantitative perspective that I think for smaller physician-led and primary care practices with limited resources to redesign clinical change and invest in the infrastructure and invest in the data analytics. Some have hired actuarial firms to help forecast costs, though this can be expensive. Others have worked with third-party firms, what we're calling sort of ACO enablers like Alidade or Caravan or others. And there are some policy solutions that we can get to in our remarks or in our discussion that might spur this as well, including maybe restarting the ACO investment model program. We've also seen an increase in the adoption of two-sided risk models. 37% of MSSP ACOs were in two-sided risk in 2020, make sort of a continued trend that we've noticed over the last few years. And this has been driven in part by the inherent design of MSSP, and the stated goal of CMS to shift more organizations into downside risk. But this has had a material impact on performance and savings, with ACOs in two-sided risk models more likely than those in one-sided risk models to receive bonuses and generate savings. Part of this, again, may be attributed to survivor's bias, with organizations that are already performing well tending to stay in the program. And our research has also shown that slightly more ACOs in upside only arrangements did indeed drop out of the program than those in downside risk arrangements, which is a trend that's held up over time. But it's also because ACOs that are able to invest in developing their capabilities have improved and undertaken the changes needed to succeed in MSSP. Downside risk can be a big motivator for organizations to take more seriously the transformation needed to succeed. And this materializes in a number of ways. For instance, ACOs in two-sided risk models are more likely to invest in care management services, develop better data management capabilities, or establish care coordination and the staff required to manage their beneficiaries' care. So this is all to say that downside risk can be an effective catalyst to help drive care delivery transformation. In terms of looking ahead, there are a number of developments at the federal level that will have significant impact for the direction of ACOs moving forward. In particular, the recently announced strategic refresh at CMS, CMMI, as well as directive statements from Center for Medicare and CMCS spells out clearly that accountable care and the ACO model will continue to be a foundation upon which payment reform is built. CMS has explicitly stated that it wants to move not just Medicare, but Medicaid beneficiaries into a care relationship with accountability for quality and total cost of care by 2030. And this is in part a reflection of their effort to really foreground health equity and ensure that there is an increased focus on underserved populations and a focus on health-related social needs. There will also be broader support from CMS to partner with employers and commercial payers to drive accountable care reforms. And there will be an effort to streamline the portfolio of models. We've seen the sort of let 1,000 flowers bloom approach over the last 10 years. And I think moving forward, this streamlining will take priority, as CMS is already in the midst of redesigning existing models and developing new ones. We've seen some being phased out, as well as new ones being launched, like the ACO Reach. And there will be a bigger focus and attention to mandatory population-based payment models, which will be sort of a linchpin of this strategy, because it can help us sort of mitigate risk selection as well as promote care coordination. And then, skip the slide. Well, I can just close out with my main takeaways. In closing, and I'll circle back to this in some of our discussion, it takes resources, investment, and time to succeed, change doesn't really happen overnight. Second, small shifts from fee-for-service to value-based payment models result in small impacts. Downside risk is a big motivator for undertaking big care transformation changes. Third, there will need to be better and more multi-payer coordination. Having just one payer on board isn't sufficient, and our research has shown that organizations that do better often have more than one contract in some kind of ACO or value-based payment contract. Fourth, there needs to be better transparency and predictability, which can enable confidence. Frequent changes to program design has often been cited, at least in our sort of qualitative information gathering, has been cited as a discouragement to participation in the past. So this is something that policymakers will want to consider moving forward. And then lastly, it's good to keep in mind that payment reform is not an end goal in itself, and that further work is needed to continue to engage patients and ensure that they're sort of the focus of care delivery and payment reforms, and improving access and outcomes while lowering costs. So with that, I will turn it over to David, who will dive into some of these issues in a little bit more depth.
Thanks, Jonathan, and it's great to be with all of you today. And I'm going to talk a little bit more about some of the aspects of what we're seeing with different types of organizations and how those result in material performance for the ACO. So this is looking at physician groups and hospitals and understanding who is involved with accountable care and who is driving and who is succeeding. So initially, I'd like to show a classification of ACOs that we put together a few years ago. And the point of this was to show the breadth of organizational structures that are involved with forming these risk-based organizations. And if you kind of group them into categories, you can see that there are what we think of as full spectrum integrated. These are the integrated delivery systems that own or employ physicians or physician groups, and they have the hospitals and they have post-acute care. And these are really kind of what people, when they were initially thinking about ACOs and kind of this transformation, thought that these would be the organizations that were going to be involved. There's then some that are hospital-led. Hospital-led organizations have a hospital, but obviously they need to provide some level of care through physician services. And sometimes they create partnerships with them, with separate hospitals or with separate physician groups. Other times they kind of say, let's treat people inside the walls of our hospital, but when somebody goes and is treated in the clinic, it's going to be kind of out of sight, out of mind. We're going to hope that it's really good, but we're going to manage things from within the walls of our facility. On the other side is where you have the physician-led ones, and those are also very different, where you'll see physician groups that will form an ACO all by themselves. Oftentimes they are providing directly all the outpatient care, but then again, if somebody gets admitted to a hospital, then it's kind of a black box, and they hope that care goes really well, but then when the patient is released, they're able to help manage them and care for them and hope that the costs aren't excessive. Alliances are where you see multiple different physician groups come together, and then the expanded physician group is where the physician group is leading it, but they will create sort of partnership arrangements with the physician, with hospitals or other facilities to help manage the care. Why it's useful to think about these is just recognizing that when you say an ACO, it does not mean every ACO is the same thing. They look very different. They're structured different ways. They use different technology, different facilities, different skill sets, different personnel. And so a lot of different approaches that people are taking, and we're starting to get some really meaningful learnings about what works and what doesn't work, and what is successful, where there are really good ROI investments, and other things that might be helpful but will end up costing more money to the organization in the long run. So if we look at some of these types, classifying them into these larger groups over time, this is from a relatively recent study that we did. We looked at who was forming ACOs over time. Initially, it was these more integrated organizations, the large health systems that people were envisioning when ACOs would form. You'd say, oh, we're going to take full risk for population, but we're going to be able to directly provide that risk. We're going to be able to own or employ all of the different skills that are needed to care for that population. What we've seen that over time is that those more integrated organizations have become the minority in terms of new entrants into the ACO program. We're seeing, in fact, a majority of new ACOs in the past few years being formed by physician groups. Now, there's a variety of reasons for this. One of those is that there simply are significantly more physician groups out there than there are hospitals or health systems. And so there is just more market potential for these organizations to come together and form an ACO. Another thing is that there is a business model around forming an ACO focusing on the patient or the physician side of care. For example, the most expensive form of care is hospital inpatient care. And one of the most successful ways to save money and be profitable is by reducing those unnecessary admissions. And so if you are a physician group, you're able to get paid upfront for providing care in an outpatient setting, and then you also get a bonus payment down the road. If you're a hospital, it's a little bit different because you're still getting paid day by day through a fee-for-service chassis, a fee-for-service mechanism. And so if you start reducing hospitalizations, you actually reduce your average daily census. So your heads in beds drop. And you hope that over time, you're going to be able to make up that money when you get a bonus payment because you've reduced the total cost of care. But it's uncertain, and it's also a very long-term time to wait. It's really difficult when you reduce your utilization every month and you say, well, hopefully 7 or 8 months after the end of the calendar year, we're going to get a bonus payment that's going to offset all of those losses. And so there's just some general structural things that make it a little bit easier for physician groups to potentially form ACOs and start to manage these populations. As Jonathan was mentioning, there were some, I think you go to the next slide. It's gonna go forward for me. This is looking at the ACO growth over time. And this is going up through second quarter of this year. So just most recent data. And this is looking at the number of ACOs and the number of lives that are there. And as Jonathan mentioned, there's been a plateauing of organizations that are here. And for all of the reasons that he talked about, I think that that's correct. But there's also more of a story around here than just the plateauing that's happening. It's that there continues to be significant growth and both investment into ACOs and also dropping out of ACOs that's happening on. So it's not a flat plateau, it's a very tumultuous plateau where we're seeing organizations that are joining and others that are leaving. And so there are a variety of reasons why organizations form an ACO initially. Sometimes they say this is really the way that we're going to manage our patient population and we can provide great outcomes that way. It's purely mission driven. Others say there's a strong business case for it. We think that we can make a financial return. Others say we think that this is how we've always wanted to practice medicine. We wanted to care for people, get paid for keeping them well, as opposed to waiting until they get sick and then trying to fix their problems. But there's also a variety of reasons why people drop out of the program. And the first and largest reason is that they're just not able to be successful. And the reason that ACOs are not successful, they're not able to save money, is as long as there are numbers of ACOs that have left or quit these programs. And there's a lot of challenges and a lot of opportunities when you learn what's going on. One of the big challenges is that the fastest way to be unsuccessful is to invest significant resources into initiatives that don't actually help. And so if you spend a lot of money for patients that don't need it, then you're going to cost more and you're not going to be able to save money. Another challenge is that sometimes the operational side of it is just too difficult, where you have people that maybe you had a company retreat and the leadership said, yeah, let's go for it and form an ACO. But then when they get down to it, they realize there are too many organizational barriers that keep them from really coming together, from really providing that optimized care that you'd like to see happen under one of these models. Other times people get new leadership. Over this, the map that or the chart you're seeing here, this is a dozen years. And over that period of time, there have been countless organizations that have seen transitions in senior leadership, in their boards. And not always is this priority of focusing on value-based care consistent between one leadership group to the next. And so we're seeing people that say, well, it was a great experiment, but we're going to focus on something else right now. So there are a lot of different reasons and little factors that are influencing and driving what's going on and why there may or may not be organizations that stick around in the long term. Now, we talked briefly about this idea of physicians versus hospitals and some of the reasons that one versus the other might be better situated from it. Now, this is a little bit of old data, but similar trends have happened in more recent years. And this is just looking at the overall performance. This is looking at the Medicare Shared Savings Program, and it is saying how financially profitable were these organizations. So what was the average savings rate across all these organizations based on who was leading them? And you look at this and you say, oh, physician-led ACOs did twice as better as anybody else. So they say, what is the reason for this? What's driving it? And there might be incentives to say, let's focus on physician-led organizations. Well, the reality is that both hospital-led and physician-led ACOs do quite well. So if we could go to the next slide, this will show an overview of the performance. This is the distribution of performance for physician-led and the hospital or integrated systems. And you see that, well, on average, physician groups do slightly better. There's actually a lot of overlap among them. And so we're seeing that you can do well as a hospital-led or a physician-led ACO. And the question then is, how do you do it? And what we've done here is shown on this next slide is a marginal effects analysis. If somebody could advance that. This shows what happens if you go from the 25th percentile to the 75th percentile of utilization for different care services. How do you do as it relates to your savings rate? So those that do provide more primary care service, on average from the 25th to the 75th percentile, will save 2.5%. If you go down to things like doing more, having more hospital discharges, then you will lose money. And if I could simplify everything that we've seen about ACOs in a nutshell, it is more primary care leads to better performance as long as it's able to successfully reduce hospital admissions and skilled nursing admissions. So that's really what the key is. And whether you're a hospital-led or a physician-led ACO, you're able to do that. And with that, I will finish up my presentation and go to Mai for some conversation.
Thanks, David, and Jonathan is rejoining us. So I want to open it up and just follow up on, David, your numbers about primary care and ACOs. And I think this reflects a couple of questions we received from the audience ahead of time as well, which is, what really is the opportunity here for ACOs and primary care to help one another? Besides just saying more primary care, what do you think the specific approaches and strategies, relationships there could be that you don't see enough of yet?
I'll give kind of two ideas that I think are right at the top of the chart. The first one is significant and persistent communication. This is where they are letting each other know what's working and what's not working, with a commitment to improve over time. And oftentimes we're seeing that this is a subset of the physicians that are doing a lot of the kind of nuts and bolts of managing a population, learning what works and being able to disseminate that across the broader organization and finding out what doesn't work just as importantly, and making edits as needed. The other thing is really providing data and expertise to help people make a meaningful difference of care treatment plans at that point of contact with the patient. It's one thing to say, in general, you should do more ABC types of treatments for patients. It's very different to say, when you're meeting with a specific patient, what are you going to do differently today than you would have before? And being able to have both data and interventions that are available, as well as mechanisms to encourage and to help track what is being done differently. We've seen this with many ACOs where they say, we've got a plan, we're going to go and make all of these changes, but then in practice, they don't change things day to day at that bedside, at that point of care with the patient. So how do you identify those, measure those, and help optimize those?
Well, so Jonathan, let me push a little bit on that. If that's the nitty gritty, then how does that relate to how primary care practices should think about ACOs in the context of all the pressure they're getting to become affiliated with hospital systems? What is the relationship between the ACO movement and trying to keep independent primary care alive and well?
Yeah, that's a great question, and I think is often brought up in these types of conversations. I think those concerns are very valid, but there have been plenty of examples of primary care practices participating in ACOs where they are able to maintain and even strengthen their ability to negotiate in the market. And I think part of that is supported by working with third parties in a way that doesn't necessarily lead to loss of ownership, loss of decision-making, but can access upfront capital or the technical assistance to undertake that transformation without leading to consolidation or loss of ownership. And I think that also is a related policy question on behalf of what the federal and state governments can do to provide the support needed for some of these smaller resource-constrained organizations to participate in the transition to risk-bearing arrangements.
So if I heard you right during your comments, there seems to be a few proposals out there that would tend to address several of these issues at once, helping under-resourced practices, perhaps reversing the slide in ACO participation, keeping independent practices independent. You had mentioned the AIM model and the REACH model. Could one or both of you speak for the audience, just the basic outlines of why you think those models may be play such an important role here?
Yeah, I'll take a shot at it, and then David, I'll turn it over to you. I think the ACO AIM model provided a portion of upfront savings so that smaller organizations could invest in the infrastructure that might enable them to succeed down the road. And it was one of the few programs sponsored by CMMI that sort of met all their criteria for becoming a permanent program. And so it was successful by all the metrics that they set out. And then in terms of the ACO REACH, is that the second program, the ACO REACH? We're doing a lot of analysis on the different design components of it, but I think some of the key features that make it attractive are a simplification in terms of some of the model components, as well as the equity benchmark, which provides a flat $30 per beneficiary per month payment for organizations that primarily serve populations that have been marginalized. And so I think that is an attractive feature that can help organizations that might not have access to a lot of financial capital or know-how to get the upfront funding that will then enable them to succeed down the road.
David, do you think that those models go as far as they should in the goals that they're trying to reach? And what other strategies should be on the table for reversing this slide in participation?
So one of the challenges obviously was the pandemic. When people are worried about treating massive populations that they haven't done before, it was just a distraction. So for a couple of years, I think a lot of leadership just kind of moved beyond this and said, yeah, value would be nice, but right now we've got a crisis that we need to address. And so this year, we're starting to see more organizations that are kind of taking off their COVID blinders and saying, look, what should we be doing, and really preparing for the future. And the example of this is that organizations that were further along this path actually did a lot better during COVID because getting prospective payments or other mechanisms was a better business model rather than working under a fee-for-service system, particularly when elective services started to drop during the early days of the pandemic. So I think there's at least a willingness of people to move forward. The challenge comes down to what changes are organizations really willing to make. And transforming to become a true, what I think of as an ACO, where you're really focusing on the well-being of a population, means that you need to change all sorts of things. You need to move to use technology differently. You recruit your workforce and train them differently. You focus on facility light care, where you're trying to eliminate these high-cost locations. And it's a business model change. And it's just a challenge for these organizations. And so one area where I think there could be investment is more of the organizations that are building something anew as opposed to trying to transform what exists today. And so incentives for organizations that say, let's, rather than starting with these very costly hospitals, let's start with no facilities and then only build the bare minimum of what we need and start to move up from that direction. So I think if there could be investments or programs that facilitate multi-year contracts that give people flexibility to kind of these startup costs to get factored into them, I think could really drive some novel approaches that aren't dependent on what I think of as a legacy business model.
So a man after my own heart to talk about a lower cost operating model, because I think we sometimes forget that profit margin is your revenues minus your input costs. So you actually have ways to manage both of those pieces of the equation. What about what policymakers can do beyond what they already have? And I'll just plan to see, you know, what would motivate someone to go and start an ACO if they're doing just fine? What can policymakers do to shake up that situation?
Yeah, first of all, I think policymakers need to be willing to create the burning platform that's going to drive change. And so we've seen this time and again that whenever there is a major change that's happening with Medicare or even Medicaid, then people are going to push back, and they have the ear of their members of Congress, and so it's really hard to make these substantive changes. And so I think there's a couple of things that could happen. One is wait for a pre-existing crisis to develop more fully, and then be ready to make those changes. And one of those that's coming very quickly is the Medicare Trust Fund. What happens when it's exhausted, which could be as short as 4 years from now. And if that's exhausted and all of a sudden Medicare says we're going to start paying 83 cents on the dollar on changes, then people will say, oh, maybe I can be willing to make that change. So the first one is just is creating that sense of urgency for the organizations that are there. The second idea is making what works better known and better disseminated across the country. And this is something that I've been a part of for a number of years, but it's still really hard. A lot of people say, well, I know what works when I see it, but how do you take what works in one location and replicate it elsewhere? Because I've seen a lot of organizations that start to go down the pathway to transforming their own delivery of care, but then they get frustrated because they're not being successful and they're making the same mistakes that lots of other people have. Or they try to replicate what they learned about at a conference, but it just doesn't work within their organization. And so that organizational learning, that transformation learning is an important piece of that. And I just don't think we have enough of it yet, and particularly the dissemination isn't as available. That's why these ACO enablers are helpful, because they take learnings from organizations and really work with them, but it's what we're at today is not sufficient.
And just, oh, sorry, go ahead, Jonathan.
Just building off of what some of the points that David just made, I think there are a couple other points I'd like to add to that. One, and this is echoing some of your writing, that we could make changes to the Medicare physician fee schedule so that it's less attractive than some of the value-based payment arrangement models. And then I think in terms of more discrete and prescriptive policy reforms, CMMI states could support the learning collaboratives that David just mentioned. I think that's always been a consistent denominator in things that have helped organizations succeed in value-based payment arrangements. More access to, or sort of more timelier access to data. The delays in knowing how well you performed is a significant impediment to sort of adjusting and tweaking how you respond and how you're undertaking care transformation. Third is sort of simplifying a lot of the different administrative back-end changes that are needed to succeed in these payment models. And part of that is sort of wrapped up in this discussion around multi-payer and aligning different measures. And then I think fourth, there can be a little bit more, at least in our research, speaking with a broad variety of different stakeholders on the ground, there can be a little bit more clarification from policymakers and some of the program officials on what activities may or may not sort of adhere to the program descriptions. I think there has been, for instance, getting a little bit on the technical, but from the adoption of waivers, for instance, we've often found that despite the plethora of different waivers that are available for organizations to use, they often don't use it out of sort of perceived fear of legal risk or ramifications. So I think just a general overall more guidance from some of the programs might be helpful.
I actually have a question for you, Mai, to put you on the spot. So you're one of the few people that has really in-depth experience from the public payer side and the private payer side trying to make ACOs be successful. What could be changed to make the alignment between public and private payers more successful? I mean, there's a lot of barriers, but what could make it work out better?
Yeah, it's funny. I was just going to throw that question out to you guys because I do think it's important for us to remember that providers practice in a whole market. They don't just practice in Medicare, and they have to make rational business decisions taking into account their whole book of business. And I think that there are some really critical challenges in other sectors, in Medicaid and in commercial. We have to remember that the populations are different and they need different things. And it's the fact that commercially insured patients simply don't spend as much money on healthcare services as people in Medicaid or in people in Medicare. And so your strategies may not be directly transferable from your MSSP experience or CMMI experience into one of these other sectors. I do think, though, that one common challenge that is probably amplified the most in the commercial space is that the current business model of not value-based care is much too attractive. I don't think that's true for every provider. I think that many, especially independent primary care practices, do not feel like they have a lot of market leverage. But the challenge is that for those providers that do have market leverage, that is the galloping business model. It is not value-based care. I have too many examples of health systems who tout their value-based credentials publicly, but in private are negotiating double-digit fee increases that just eat up whatever savings they might generate from lowering utilization. And that sets up a certain culture within their organization. And then I don't think any of us should be surprised that that binary, ambivalent culture undermines whatever well-intended work you're trying to do on the value side. So those are some initial thoughts, but I would love to. So my feeling is I'm at the point where I feel like across all these sectors, except in Medicaid, what we need is some way to rein in growth in prices, because it is when providers see the growth in prices that is the allure for them of not going into value-based care.
And this is, I'm a firm believer in that as well. It's that as long as price can grow almost unconstrained, then we're never going to be able to see the meaningful change in costs, and we'll also not be able to see the outcomes that we want in terms of delivery transformation.
And I think to that point, especially for this audience, again, not all prices are equal. And a high value system does not mean that we should try to control prices or generate savings from every part of the system. We do not think that there are overly high prices in primary care. That's not the point. But when prices are too high for certain types of services or in certain sectors, like inpatient care, like specific procedures, it means there's less left in the pot to cover the things that might actually make a difference in health. So on that point too, though, I want to ask you all to opine a little bit on this, on the issues of equity, because we've given a nod to it, but I know that you both have been thinking about this a lot. How beyond the REACH model should both ACOs and policymakers really make sure that equity is integrated into value-based models?
I'll take a shot at this first and then kick it over to you, David. There are a number of different approaches. I think one, you could replicate some of the design models in ACO REACH, like the governance structure and ensuring that patients have an active voice in the leadership or in the sort of the board and organizational structure of the organization. I think emulating the ACO REACH benchmark is a good first step. There are a number of different measures that can be implemented that better assess whether we are meeting certain health equity benchmarks. I think further push on getting ACOs off the ground in terms of the Medicaid space is also significant. And then I'm not well versed in this, but certainly adjusting risk adjustment methodologies to ensure that organizations aren't discouraged from providing care to certain communities is a critical first step as well.
I think there's two areas that I would focus on first. The first one is a better measurement, because we can't improve what we can't measure, and we do a really poor job of measuring health equity outcomes. The second one is when you say what measurements should we be focused on, I think we need to do a lot better with patient-reported outcomes and whether the health system is meeting the expectations of the patients that are receiving the care. We're really good at looking at A1C levels or readmissions, but what about the patients? Are they getting the care that they want? And ultimately, I think that's got to be a more important factor than it currently is today.
Yes, so with my disability hat on, I will say that I wholeheartedly agree with that what matters in health should be what matters to people. But with that, let me ask Anne to chime in if we've gotten questions from the audience, and let's open up the discussion. I'm not. Okay, well, we don't have any questions yet, which just allows me to push you guys a little bit further. When you think about the alignment across different payers, alignment across quality metrics, that's certainly been a long-standing and chronic theme. In what other ways do you think alignment across payers could help rejuvenate the energy and momentum for ACO work and other types of value-based approaches?
I think payment design, there's a big opportunity there to where you have, not that you have to have everything be the exact same, but you have standardized principles that people are starting from, and so that they can make changes or opinions or approaches within those standardized designs. Right now, beyond just the variation of quality measures, the way that you can do everything from benchmarking to attribution is so inconsistent across payers that many times the physicians themselves have no idea who they're responsible for or for what level. So you can make that more consistent. That would be one step further.
Yeah, I think building off that, sort of standardizing contracting across different payers could be a significant first step. And then alignment and sort of reporting requirements, not just measures, but what is reported and how. Just anything that can be done to streamline and reduce some of the administrative burden on the back end can really help spur primary care and other sort of low resource organizations to make those first steps into value-based payment models.
Yeah. And do you think that there is any opportunity, David, to your point about this notion of a lower cost operating model? Do you see organizations out there that are either have major pieces of that type of model or that could naturally grow to become a different kind of ACO, a more modern ACO?
Yeah, there's a lot of organizations. A lot of them are doing this through Medicare Advantage. So this is the Oak Street Health and ChinMeds and CareMores of the world that are really doing meaningful things in the delivery of care. One of the challenges that they have is that most of these business models are heavily dependent upon very sick populations. And so there's not a real great way of providing intense primary care for healthy populations and still being profitable around that. And so I think there's a lot of opportunity to continue to say, how are we going to manage people that are generally healthy, that periodically will have issues, but how do we treat them in a way that's going to be successful and low cost? And some of that I think is going to be technology driven. I have yet to see a true virtual doctor that is anywhere near as good as any doctor that I've been to, but are there going to be things that allow people to say, I can get care at a much lower price, at a much more convenient way, and be able to lower the total cost of care through that mechanism. But I think there are opportunities, but you know, it's going to take time to develop them.
Maybe we're measuring success wrong. Maybe what we should be measuring is health and spending 10 years from now or 5 years from now, rather than on a calendar year. Because I am imagining that someone who is kept healthy will ultimately cost the system more than if they become sick enough to enter one of these high cost, high need models.
I think that the longer term contracts are great. I mean, there's obviously the challenge when people are moving and geographic changes that happen. But I am a big proponent of multi-year contracts. So I don't know if we're going to get to 10 years right away, but if we could just go to a 24-month contract, for as an example, that would be a lot better than what we're seeing today. But yeah, the longer that somebody sticks with a plan or with a provider, the better opportunity there is for the interventions to realize that ROI.
And David, have you seen examples of that? I think from our research, we're super curious in that, but I've not seen much to date on that. No.
I've heard a lot of people talk about it, but I don't know of any examples that have gone beyond a year.
Well, there's sort of accidental examples in the commercial space. It's not uncommon to roll over reconciliation after 1 year into the next year, depending on the insurer's relationship with the provider. Sometimes that just makes sense if you know that they're doing good work, but the scorecard just doesn't look right this year.
I think the one area that on the policy side that we could really do those multi-year contracts are in the SNPs, the special needs plans. So if you look at a dual eligible and say, look, unlikely that they're going to be moving geographically. If they're dual eligible on a SNP this year, they're going to also be there next year and do a 3 or even 5 year demonstration program and say, look, long-term commitment, let's see what the outcomes can be.
Yeah. Yes, I was just thinking about also what it means to measure health and outcomes. We, as David, as you said before, often we miss what is most important to patients. I also wonder if we're just missing the level at which we should be measuring. We've been very focused. We call it population health, but it's not really, right? It's person level health that you then add up to a population, which is not the same as thinking about the health of the community, in which case you're somewhat less concerned about a small number of people flowing in and out of the population. And I know that is a philosophical reach for ACOs, but it is in reality what drives health, right? The park near me is not an investment that an individual ACO will make, but that park makes a great deal of difference to my mental health.
Mm-hmm.
And part of that is, and I would be curious as your thoughts, Mai, here, but we don't have the infrastructure to support that sort of rolling up to the population-based level right now. So I would welcome your sort of insight on, I mean, I'm optimistic on I think there's a lot of conversation around this exact issue, but where you sort of see the most critical levers to get there.
Yeah, lately I've been thinking about this analogy to climate change. Because I've been thinking, climate is all around us, and it's not any one person driving either the problems or the change. We would never actually go to the fossil fuel industry and expect leadership on climate action. And so there's a part of me that is befuddled by why we wait for healthcare incumbents to figure out how we get to health as opposed to healthcare services. But what we do know from that analogy of climate action is that when government and the community put out clear expectations, like quantifiable expectations, like emission standards, or offer opportunities, financial opportunities like cap and trade, somehow the financing appears for people to develop solutions, because money can be pretty smart and investors know how to seek out those returns if there's a reasonable enough business case put in front of them. And even just the cultural expectation, the change in cultural expectations, that it is not okay to not think about climate impact whenever you're reviewing a proposal for a real estate development, for example, or for a new factory. And I wonder if we could move in the direction of having health impacts. And so that it's not all reliant on ACOs, but on a broader set of activities that lead to community health, where ACOs are playing a part. And then it may be easier for all of those health system executives to have the conversation with their CFOs and say, yeah, we could make more in fee-for-service, but we have these regulatory requirements to meet on community health. So I see Anne signaling time, so I'm gonna thank you both so very much and turn it back to her. And we can't hear you.
Sorry about that. Thank you all for joining us all today. It was a fascinating conversation. We could go on much longer, and clearly would love to explore this larger question about how we measure effects at the community level. Please join us for our webinar next month and have a wonderful afternoon.